All right, today we are diving into a really critical topic, how to safely guide a patient with diabetes through surgery. It's kind of a medical high-wire act, and we are going to walk you through the entire playbook.
So just think about it for a second. Diabetes is one of the most common chronic diseases out there, right? And surgery is one of the most common things we do in medicine. So what happens when these two massive worlds collide?
Well, it creates this incredible high-stakes balancing act. Seriously, from the second that surgery is scheduled all the way through recovery, every single decision about blood sugar directly impacts the patient's safety and how well they do. This is precision medicine, but under some serious pressure. To really get a handle on this, we're going to break it down into a few key phases. We'll start with part 1, before the first incision, because really this is all about setting the stage for success.
Okay, for any surgery that's planned in advance, what we call elective surgery, the very first goal is getting the patient's HbA1c below 8%. Now, if you're not familiar, HbA1c is just a simple blood test. It gives us a snapshot of their average blood sugar over the last 3 months. A high number means their long-term control isn't great, and that just skyrockets the risk for things like infections and poor wound healing. So, getting this number down before surgery is almost always the safest move.
All right, so with that long-term goal in our sights, the focus then shifts to the days right before the operation, and that means it's all about medication management.
And this table here kind of lays out the strategy. For most oral meds, it's pretty simple. You just hold them on the day of surgery because the patient isn't eating. But metformin is a special case. You got to hold that one for 24 to 48 hours beforehand to dodge the risk of lactic acidosis, which is a really dangerous buildup of acid in the blood. And of course, some of the newer drugs have their own rules too. The big takeaway here is that every medication has its own playbook.
Now let's talk insulin. It helps to think of it as two totally different tools. Over on the right, you've got bolus or mealtime insulin. Since the patient is fasting, you just hold it. Easy enough. But on the left, that's basal, the long-acting insulin. Think of this like the body's background thermostat. You're going to reduce the dose for sure, but you never shut it off completely in someone with type 1 diabetes. Doing that can trigger a life-threatening emergency called diabetic ketoacidosis. This is one of those rules that is absolutely non-negotiable.
And finally, on the morning of surgery, there's one last huddle, a quick checklist. You're looking for any underlying issues, making sure they follow the fasting rules, and, most importantly, you get a blood sugar reading the moment they arrive. That gives you a crucial baseline for the day.
With our patient all prepped, we're moving into the operating room. Welcome to part 2, during the operation. Now, the name of the game is maintaining stability under pressure.
During the surgery itself, there's really one main guiding principle. Keep that blood glucose below 180. Why? Because high blood sugar, or hyperglycemia, directly messes with the body's immune system and slams the brakes on the healing process. It's like rolling out the welcome mat for post-op infections. Staying under this number is absolutely key for a good outcome.
So how do you actually stay below that target? Well, it takes constant vigilance. This timeline shows you the workflow. You get a glucose check right at the start, and then you monitor like a hawk, every 1 to 2 hours. If that number starts to creep up over 180, you jump in, usually by starting an IV insulin drip. It's this continuous loop: check, assess, and act.
An IV insulin infusion is really the go-to tool for managing high blood sugar during an operation. It's a continuous drip, so it gives the anesthesia team incredibly precise, real-time control. Now, what's interesting is that it's often paired with a dextrose infusion. You might think, wait, you're giving them sugar too? But it's actually really smart. The dextrose provides a steady trickle of energy and acts as a safety net to keep their blood sugar from crashing too low.
Okay, the surgery is officially over, but we are far from done. The time immediately after surgery is just as critical. So let's move on to part 3, the road to recovery and how we transition the patient back to normal.
And hey, that number should look pretty familiar by now. Keeping blood glucose at or below 180 carries right on over from the OR into the recovery period. Consistency here is everything. It's what prevents complications and helps ensure the recovery is as smooth as possible. This slide really highlights a major shift in how we handle post-op care. The old method, what's called sliding scale only, is totally reactive. You're just chasing high blood sugar after it already happens, which leads to this roller coaster of ups and downs. The modern, preferred way is a proactive basal bolus regimen. This gives a steady 24-hour background insulin plus extra coverage for meals, It leads to much, much better and steadier control.
Getting a patient back on their home medications is a carefully choreographed process. You can't just flip a switch. As you can see here, you first wait until the patient is eating reliably. Then you transition them off the IV insulin and onto subcutaneous insulin, the injections under the skin. And only once they're eating normally and are stable do you restart their regular oral diabetes meds. It's a very deliberate step-by-step handoff to keep them safe.
Whew! We have covered a lot of ground, so let's wrap things up and distill it all down in Part 4, Key Takeaways. These are the core principles you've just got to remember.
If you remember nothing else from this, remember these 4 golden rules. 1. Get that HbA1c below 8% before an elective surgery. 2. Never, ever stop basal insulin in a patient with type 1 diabetes. 3. Keep that glucose below 180 during the operation. And 4, use a proactive basal bolus plan after surgery. These are the absolute pillars of safe care.
And that brings us to our final and honestly our most important point. Guidelines are the map, but they are not the territory. As this quote says, the plan has to be individualized for every single patient, every single time. Every person is different, every surgery is different. Tailoring the approach is what separates good care from great care. So maybe the final question isn't just how we follow the rules, but how we build systems that empower us to see beyond the protocol and truly treat the unique person right in front of us.